Hey guys, it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be going over Graves' disease, which is one of the most common causes of hyperthyroidism that is most likely to show up on step 1 of your boards. So before we dive into the nitty-gritty of Graves' disease, first let's review our general findings of hyperthyroidism, since this is a cause of hyperthyroid state. And remember, when we talk about hyperthyroidism, I want you to think of our hyper guy over here. So our hyper guy is super metabolically active, his battery is all the way up. He is going to be super hot because he's burning through all this energy. He's going to be sweaty, he might have weight loss because he's burning all these calories, diarrhea, and then it's like he's super caffeinated. That's why he has his Red Bull. So he's going to be hyperactive and restless, and he's going to have insomnia because he's not going to want to sleep. He has too much energy. He might be anxious, have fine tremors, palpitations, and hypertension. So all these things that go along with our hyperthyroid guy, I want you to keep in mind because they will be a key part of the presentation for Graves' disease, which is of course a cause of hyperthyroidism. And then before we dive into the histopathology of Graves' disease, I think it's important to revisit our pathway for thyroid hormone control. So remember, we start out in our hypothalamus. Our hypothalamus releases thyrotropin release hormone. That is going to travel to our anterior pituitary. The anterior pituitary stores our thyroid stimulating hormone. Our thyroid stimulating hormone then of course goes to the thyroid. And then our thyroid stimulating hormone goes and binds to a receptor here on our thyroid to induce the release of T3 and T4. And that's going to be a really important part of your guys' understanding of this pathway, because what's happening in Graves' disease is we have this autoantibody, thyroid stimulating immunoglobulin, so it's an IgG autoantibody, and that antibody is going to be binding to this receptor that thyroid stimulating hormone usually binds to. So instead of thyroid stimulating hormone binding to this receptor here, we are going to have our IgG binding to this receptor, and that IgG is our thyroid stimulating immunoglobulin binding to our TSH receptor, and it's going to have the same effect as if TSH were binding to that receptor, and then it's going to increase our release of T3 and T4. So we have the increased release of T3 and T4. This is of course a type 2 hypersensitivity reaction. It's type 2 because when we have IgG, that lone autoantibody causing our hypersensitivity reaction, that is type 2. It's not a complex, so it's not type 3, it's not IgE, so it's not type 1, it is type 2. This is also going to be associated with our HLA-DR3 and HLA-B8 types. So it's important to just memorize these and know them because sometimes they do show up on step 1. And then an important part of this pathology that actually results in a very classic presentation for Graves' disease is we're going to get this T cell activation, right? This is a hypersensitivity reaction, and when we do have too much IgG, we can get T cell activation. The T cell activation is going to lead to lymphocyte infiltration into our retroorbital space, which is a really fancy way of saying the T cells are going to invite other white blood cells to join the party behind the eyeball. And as these white blood cells join the party behind the eyeball, they're going to be releasing cytokines. The cytokines that they're going to release are TNF alpha, interferon gamma, things like that. And those cytokines are going to stimulate our fibroblasts to secrete hydrophilic glycosaminoglycans. That's a really fancy way of saying that those cytokines are going to tell our fibroblasts to secrete these carbohydrates that like water. And as the carbohydrates are secreted, this is going to cause increased muscle inflammation as well as osmotic muscle swelling. So remember, I just told you that these carbohydrates love water, so they're going to suck up a bunch of water and pull a bunch of water into that space behind your eyeball, causing the muscle to swell. This is going to lead to something called exophthalmos. And if you look over here, you can see a great example of exophthalmos. Exophthalmos is when there is swelling behind the eyeball, this swelling from the water being pulled in and from the muscle inflammation. So there's less room in that orbital cavity, and that causes your eyes to protrude forwards. You can see that these eyes are protruding forwards. This is a very classic presentation for Graves' disease, and one that I would recommend that you associate with Graves' disease in your mind. When I think about this, I always think about the actor Marty Feldman, who was in Young Frankenstein. If you've seen that movie, he had very classic exophthalmos. I think it was because of Graves' disease, and so I always think of those protruding eyeballs, that very classic look, to be associated with Graves' disease. And zooming over here on a histology image that we might see of a thyroid that has Graves' disease, you can see that we have just a ton of follicular cells. These follicular cells aren't necessarily enlarged, but there's just a lot more of them than usual. And you can also see these prominent infolding, so kind of more of this folding in of our hyperplastic follicular epithelium. So we have a ton of these follicular cells, and we have this increased infolding. And if you also look, you can see that we have these clear white spaces. And these clear white spaces, this is a giant one, but we have a lot of smaller ones. These clear white spaces, those are going to be vacuoles in the colloid, where the increased activity of this epithelium to produce our thyroid hormones has led to what we call call scalloping out of the colloid in the follicle. So you can see that we have a ton of colloid here in the center, and the white spaces are where we're seeing this scalloping out of the colloid because we just have so much activity of our follicular epithelium. So key things to remember about our histology in Graves' disease, that we have these tall, crowded columnar follicular epithelial cells. And then additionally, those increased white spaces, that is the scalloping that you can commonly see with Graves' disease. So we've already talked a little bit about the presentation of Graves' disease with the exophthalmos, but another important part of this presentation is that this is actually the most common cause of hyperthyroidism in the US, and it's really common amongst females 20 to 40 years old. So usually when they say a young woman comes in with these classic presentations, it sounds like hyperthyroidism. Graves should definitely be on your differential. Patients with Graves' disease can present with all the hyperthyroidism symptoms that are associated with our hyperthyroidism friend up here, in addition to goiter. Remember, we've talked about how iodine deficiency can cause a goiter. Because we're making so much T3 and T4 rapidly, we have a lot of follicular cells that have multiplied, even though they may not be larger, so that can lead to a neck mass or a goiter. We also might see pretibial myxedema, so usually that redness or skin discoloration on the front of patients' shins. We can see the Graves' ophthalmopathy, and that is a combination of the exophthalmos that we just talked about, as well as lid retraction, and that creates this characteristic look in the eyes of patients who have Graves' disease. But what will we see when we do laboratory tests on patients who have Graves' disease? Well, something you'll see is increased T3 and T4. That makes sense because I told you that we are hyperthyroid and releasing more T3 and T4, but we will actually see decreased TSH. Why would that be? Why would we see decreased TSH? Well, because we have an antibody that is binding to this TSH receptor on our thyroid, we don't actually have any dysregulation of the negative feedback in this pathway. So when we have super high levels of T3 and T4, those are still exerting our negative feedback on our anterior pituitary and halting the release of TSH. So our TSH levels are going to be super duper low because we have so much T3 and T4 present, and this isn't an actual dysregulation of the anterior pituitary, but more due to the fact that we just have this antibody that is binding to the TSH receptor. Finding these anti-TSH receptor antibodies in the serum is going to be pretty diagnostic of Graves' disease. There's a few things that can also cause this, but when you see these antibodies, you should have a heightened suspicion for Graves' disease in particular. And then additionally, you'll see diffuse uptake on thyroid scintigraphy. So we just have a really active thyroid that if you feed it any radioactive iodine, will definitely be sucking that up in high quantities to make more of our thyroid hormone. So that's why you would see diffuse uptake on scintigraphy. Additionally, patients with Graves' disease might have decreased cholesterol on a lipid panel. They might have decreased triglycerides, and they might have a normocytic anemia on their CBC. So other peripheral findings to look out for on laboratory testing of patients with Graves' disease. Now, there's a couple of key complications that go along with Graves' disease that are highly testable. These include diabetes, vitiligo, remember those skin changes, the discoloration of skin, as well as pernicious anemia. And then there are several really important dangerous disease states that you need to look out for in patients with Graves' disease, the first of which is thyroid storm. So thyroid storm is pretty uncommon, but it's essentially a really acute, really dramatic hyperthyroidism. So it is a life-threatening condition of untreated hyperthyroidism. It's usually brought on by acute stress, and that can be anything like an infection or a trauma, some other disease process that is exacerbating the acute hyperthyroidism. And the symptoms of thyroid storm are going to be pretty much amplified symptoms of hyperthyroidism in general. So agitation, fever, delirium, coma can definitely occur. That's one that occurs with thyroid storm, but not usually with hyperthyroidism. Diarrhea, and then tachyarrhythmia. This is going to be the one that can be a cause of death, and that makes sense, right? If you have anything that's making your heart beat incredibly fast with an abnormal rhythm, that can certainly lead to death, and that is one of the reasons that thyroid storm is incredibly dangerous. How we treat thyroid storm is highly testable, and you can remember the way we treat thyroid storm with the 4 Ps. So first, propranolol, that is a beta blocker. Remember, we are having a heart rate that is too fast, so we can use our beta blocker to slow it down. Then propylthiouracil, remember that's one of our thionamides that is going to inhibit the synthesis of T3 and T4. You can also use prednisolone. This is an incredibly inflammatory state, so we use prednisolone to counteract a lot of those effects. And then finally, potassium iodide. And you can see that right here we have a special guest appearance of your Wolff-Chaikoff wolf. And your Wolff-Chaikoff wolf is here to help you remember the mechanism by which potassium iodide is actually going to decrease T3 T3 and T4. So remember that when we administer potassium iodide, we're basically saturating the thyroid. We are going to be shutting down our TPO synthesis, which will in turn shut down synthesis of T3 and T4 temporarily. So remember that the Wolff-Chaikoff effect is the mechanism by which potassium iodide works and can be helpful in a thyroid storm. Another special case of Graves' disease that I want to talk about is fetal hyperthyroidism. So remember that Graves' disease is caused by thyroid stimulating immunoglobulin, which is an IgG. And IgG is our smallest antibody. Remember, IgM is huge, the other ones are much bigger, so it's the only one that can cross the placenta. Thus, because thyroid stimulating immunoglobulin is an IgG antibody, it can also cross the placenta. This means that fetuses of women with Graves' disease can experience hyperthyroidism in utero. Beta-HCG can also bind to the TSH receptor. It usually does so most strongly during the first trimester, because during the second trimester you have progesterone kind of counteracting these effects, but that can also certainly contribute to the hyperthyroid picture in utero. And then babies who experience this hyperthyroidism in utero can experience low birth rate, prematurity, and even death. So for a lot of the same reasons that we talked about in thyroid storm, the fact that we can have tachyarrhythmias, the fact that these babies are often underweight, this can lead to prematurity and death in these infants. So it's incredibly important that we treat the hyperthyroidism in the mother. And we treat the hyperthyroidism in the mother with our thionomides, PTU in the first trimester, right? Because we're trying to avoid aplasia cutis, and then we can move on to methimazole after the first trimester once the risk of aplasia cutis is a lot lower. Further management of Graves' disease, so we usually use propranolol or beta blocker for acute sympathetic symptoms, right? It's always important to protect the heart, so we're going to use this for palpitations, muscle weakness, etc. And then for more standard treatment, we're going to use our thionomides or our TPO inhibitors. Remember, our thionomides and TPO inhibitors are the same thing. Those are our propylthiouracil or our methimazole, and these are going to inhibit thyroid hormone synthesis, so these are going to decrease the hyperthyroid impact of Graves' disease. And then finally, a more curative pathway, we can do a radioiodine ablation. So essentially we intentionally give someone so much radioactive iodine that it is going to kill their thyroid. This is definitely contraindicated in pregnancy, because if you do this procedure in pregnancy, the fetus's thyroid will also take up the radioactive iodine and you'll kill the fetus's thyroid as well. So big no-no there. But radioiodine ablation will be curative for adult patients who are not pregnant with Graves' disease, as well as surgical thyroidectomy. So again, just taking that thyroid out because it can't make any T3 or T4. After both of these procedures, because you're killing their thyroid, you will have to put them on thyroid replacement therapy for the rest of their lives, because thyroid hormones, while they're bad in excess, it's also bad when they are insufficient. So you will need to replace those if you kill a patient's thyroid. So I know that was a lot of information, but what are some key pearls that I want you to take away from this video? Well, something I want you to remember is that Graves is a key cause of hyperthyroidism in young women. It is caused by thyroid stimulating immunoglobulin binding to our TSH receptor on your thyroid. Our labs in Graves' disease will show increased T3 and T4, but decreased TSH, because we have this intact negative feedback on your anterior pituitary. And then we treat Graves' disease with our thionomides, either propylthiouracil or methimazole, unless of course we are in a thyroid storm situation where we will use our 4 Ps, propranolol, propylthiouracil, prednisolone, and potassium iodide. Okay, but how would they ask you about this on a board style question? Well, something they might ask you is, you're called to the bedside of a 1-day-old female for poor feeding and irritability. Mom states the patient has been inconsolable, frequently crying, and disinterested in breastfeeding. On exam, the patient is febrile and tachycardic. She is in the 6th percentile for weight. Pregnancy was uncomplicated, mom was group B strep negative, but she does have a history of Graves' disease, for which she underwent radioiodine ablation at 19 years old, no history of substance abuse, and no other medical problems. What are the most likely values of T3, T4, and TSH in this infant, and what will these values likely be in 3 months? Okay, so we have a baby that is febrile, their baby is tachycardic, our baby is low birth weight, and it's not eating well. That could be a million things. Things you should be thinking about, certainly substance abuse during the pregnancy. So is this baby going through withdrawal? You should also be thinking about meningitis. Could be caused by group B strep, could be caused by something else. Certainly there's a lot of things that could cause this. We're given a very clean medical history, however, and we know that mom doesn't have group B strep and she has no other medical problems and there was no substance use during the pregnancy. This should make us a little bit more suspicious for her history of Graves' disease. A key point I want to make here is that even though mom had this radioiodine ablation when she was 19 years old, all we did is ablate the thyroid. But the thyroid is not what is producing our thyroid stimulating immunoglobulin. That thyroid-stimulating immunoglobulin is still present in mom. And as we mentioned in this video, that IgG, because it is an IgG, can cross the placenta and stimulate the baby's thyroid. So even though mom had a radioiodine ablation, because she has this history of Graves', she should have been on PTU and methimazole throughout her pregnancy. If she wasn't, her baby will have hyperthyroidism, and that is what is going to be leading to the symptoms that we're seeing in this baby. And the question goes on to ask us, what are this baby's T3, T4, and TSH now, and what will they be in 3 months? Well, right now, because we know the baby essentially has Graves' disease, they'll have increased T3 and T4, and then decreased TSH because that negative feedback is still intact on the anterior pituitary. In 3 months, however, if this baby's not breastfeeding and getting any more IgGs from mom, then those IgGs should theoretically be gone from its system. We should see our T3 and T4 as well as our TSH levels normalize as our baby goes back to a euthyroid state in the absence of this IgG antibody that it was getting from mom. Now, I know that was a challenging topic. I hope you feel a lot more confident with Graves' disease, and I'll see you next time.